Hello, everyone, and welcome to the 4:30 to 5 p.m. session of the 2025 Open Simulator Community Conference. In this session, we are pleased to introduce the presentation Integrating Training on Maternal and Newborn Care through Virtual Simulations. Our speakers are Dr. Rachel Umorin and Mr. Matt Cook. Dr. Umorin is a neonatologist at the University of Washington and Seattle Children's Hospital, where she is a professor of pediatrics and the director of the Neonatal Education and Simulation-Based Training Program. Mr. Matt Cook is a research engineer with the Neonatal Education and Simulation-Based Training, also called NEST, lab at the University of Washington, where he leads development teams of engineers and healthcare professionals in identifying and implementing solutions to support healthcare teams and improve patient safety. Please check out the website found at conference.opensimulator.org for speaker bios, details of the sessions, and the full schedule of events. The session is being live streamed and recorded, so if you have questions or comments during the session, you may send tweets to @OpenSimCC with the hashtag pound OSCC25. Welcome, everyone. Let's begin the session.
Thank you. Thank you, everyone. Thank you so much there for that warm introduction, and it's great to see you all. It's amazing that it's been another year, and I was just sharing with Lear that this opportunity comes around, and every year I think, what's the most important thing that we learned this year that I can share with this wonderful group of folks? So Matt and I are here again to give an update on our adventures in healthcare with virtual simulations and specifically focused on maternal care this year. So as you know, there's an ongoing need for healthcare professionals who are skilled in maternal and newborn care. As a neonatologist, I've spent most of my career focused on the newborns, not surprisingly. That's where my heart is. But I also recognize that there are places in the world where, and many places and many spaces in which you have a health professional caring for both the mother and the baby. And so thinking about how do we integrate that training in such a way that they can do the best for both of those patients has been a new focus of ours. In-person training, we know, requires a lot of time and resources. And without ongoing practice and what we call supportive supervision, which means that you could follow up with the learners to see how they're doing and remind them of things that they may have forgotten, the skills that we trained for start to decline. And this decline can actually be quite rapid. And once you have that loss of skill, then you can't really see the translation to clinical care. So, as you all know, we've been working in virtual essential newborn care simulations for the past probably now 6 or 7 years. This work started out with prototyping in OpenSim and then eventually transitioned into a Unity platform for a few reasons that I'll share later. But we always remember our roots. And we're, as we think about how we, structure these simulations to help to support the care, we're thinking about the gamification aspects. We're thinking about, the importance of ensuring that they can be accessed in ways that our learners who are often in places where they may not have access to a desktop computer can, get onto these. We're thinking about how do we ensure that they are, continuing to access the standardized content and the objective feedback. And so we have currently ongoing work and projects involving the left side of your screen, which is the virtual essential newborn care simulations. with all the criteria that you see there, really trying to ensure that they, can be accessed in different languages and that we can develop performance reports and that all of this is in a manageable file size. But now, today, we're going to talk about our move towards integrating maternal care simulations within the same experience. And so, uh, briefly, the simulations that we have currently are focused on how do you care for a newborn who's ill and needs resuscitation right after birth, um, or is small and needs extra care. And the new simulations are focused on how do you prevent, diagnose, and treat a mother who may have bleeding after birth. And so we are leveraging curricula which are already in existence, and supported through multiple professional organizations, including the World Health Organization, but which historically have been taught as separate courses. They will attend a 3, 4, 5 day course on maternal care with very little about the newborn, and then attend another course on newborn care with very little mention about the care of the the mother or the parent. And so, how do we take the attempt that's already there to reflect the areas of integration and actually fully bridge it by completely, um, within the experience, ensuring that they have the opportunity to care for both members of the dyad. So I'm going to pass it on to Matt to talk a little bit more about our objectives and some of the lessons learned. Matt, take it away.
Thanks, Rachel. So, our audience for this edition of maternal care, beyond our previous audience of providers of newborns, these are basic emergency obstetric care providers, and we have five main focuses. So first is postpartum hemorrhage prevention, make sure what those correct steps are, how to identify postpartum hemorrhage, and then of course how to treat it, and what to do for normal care when it doesn't happen. And then finally, of course, we put an emphasis on communication, with the mother and with colleagues, because apparently doctors, with the obvious exception of Rachel here or our other colleagues at the University of Washington, doctors seem to not be great at that. So, um, the first thing we did was map out the entire treatment flow of how to care for newborns and mothers. So, with the curriculums currently separated, we of course started by mapping out each individually, and then we had to figure out how to combine them, which is much more difficult than it sounds. So, with this, we've got this pretty well done. And so what we've done is we've mapped the entire treatment flow. It starts from pre-birth, and then we take this from to either referral of the mother or baby, or maybe both. Actually, not both. I'll get into that. Or discharge, where they're both healthy and taken care of. And we skip over the birth itself, but yes, from then on. Um, and then, so what this allows us to do is include any given scenario we want. Where we have complete control over the variables, when the mother or the baby gets sick, how they get sick, when they get sick. Um, and we are able to do this all in a single game scene, to help keep our file size low. And we are able to control this by defining the mother's and baby's, states at various points throughout our game flow. So go to the next slide. So with all these different actions that need to take place, it gets complicated. There's so many different things the player needs to be able to do, um, and we need to do it on hands-on basis. And so we've been able to boil down those complex actions into some mobile-friendly, simple mechanics. And these have been tried and true through our previous VNC work, through and with mechanics testing. So we won't get into that, but that sums up to we have basic clickables, and for some objects we can drag and drop them to show how they interact with other objects. And these just trigger different animations, and these actions can vary from the object from object to object, or in from for the even for the same object throughout time. And then, of course, for communication, we simplify that to some basic binary dialogue options with some good options, with a good option to choose and a less good option to choose. But yeah, as we designed everything, since we had this architecture already working, it all had to fit into this. All right, moving on. So we had a lot of complicated design decisions to make. And the first we discussed very thoroughly was how to utilize helpers, because these providers don't do everything in real life, and they have to be able to rely on helpers. And so we had to design how the helpers are going to fit into things. We actually explored the possibility of the users be having to do everything. Like, what if they don't have helpers? Because we're designing for low resource settings, it's possible they might not. Well, we decided to make sure to lean into the use of helpers, because if they're alone, well, that's unfortunate. They might have to muddle through. But as far as the learning objectives, we decided they forcing that complication didn't add anything to learning what they were supposed to do in response to these different issues. Um, so we decided that when one patient is sick, the helper has to care for the other. So this created some technical and logistical complications for our helper. Like, okay, so what do they look like? Do we have to model a full humanoid person in the room? Do we have just floating hands and a head and a torso? Um, what do they do after they complete a task? We can't have them just stand there stationary because that's not very realistic. But they can't exactly go on to the next one because, well, what is that next task supposed to be? We haven't assigned them a task. What does that mean for our flow? Who's creating these animations? How is this all supposed to work? And then, of course, if they move into the next thing, how does the player's pace move in? Because some players are going to be faster or slower than others, and we're not exactly going with real time realism with these actions. Um, so ultimately, what we decided is the helpers are invisible, except for the hands for certain tasks. So in the picture, we have the helper listening to the patient's heart rate and tapping it out for the provider or the player to see. Um, and so if they're invisible, well, how do we initiate communication with them? How, how do you, how do you do that intuitively? And so we decided that when you call for help, a dialogue option is going to pop up, and you have to give the helper simplified instructions. So something along the lines of "Go help the mother," or "Go help the baby." We are assuming that the helper is an expert, they know what to do. What we're focusing on with with these instructions is that we're practicing when to communicate and basically what to communicate about, and just showing that the importance of doing so. And then for some actions, we have some basic delegation by clicking on an item. So if there's multiple actions the helper could be doing, and you were supposed to be delegating which of them to do, we go click on an action, or click on a thing, and instead of us being the one to interact with it, it's basically us cueing, like, hey, that's next. Helper, you know what to do. You're the expert. Go and do it. All right, move on. So, in addition to communicating with the helper, we also have to communicate with the mother. Um, and in order to provide proper dialogue, in order to like be really truly realistic and proper, that dialogue wouldn't really fit. We don't have the space for it, and we also don't want to give away what the next steps are. So it's, we're going to sweep your uterus now. Like, okay, well, great. Now the game's told us what to do next. That's not helpful for learning. So when we can, we try to include some more generic dialogue. So we say, we're going to do a procedure now, and this could be painful. We're sorry about that. So something that doesn't give away, but something that's respectful and simple, because it's important that we keep that word count down and our language simple, because of course, space and users don't read. So yeah, keep that small. Okay. Time management was a big challenge. You wouldn't think it would be, but when you start to really get into the weeds, it led to some really detailed discussions. Because when you have the neonatal care or the mother care individually, there's time lapses between things. So we're doing controlled cord traction, or we have to have actions that take place. We check in on the mother or the baby every 15 minutes. So individually we have a lot of dead time, and we get to rely on time skips to maintain that appropriate timing and skip over dead time. Well, now suddenly when we're balancing both patients, what was dead time for one patient is now time you have to go spend on the other. And the curriculum, we had to stick to the curriculum, and the curriculum is very clear. You check on the patient every 15 minutes. And so this one little detail on the clock in the game complicated things, and that's the clock on the wall. We have to have the clock on the wall because it's important, especially for newborn resuscitation, that we're able to keep track of time. And so it's keeping real time in the seconds. And so now suddenly we at players different paces, we may go from one patient to the other, and then we have to come back to that original patient on that 15-minute interval. Well, suddenly the clock isn't reading 15 minutes either. Maybe it's most likely much too soon or much too late, but it creates problems if someone's paying attention to the clock, which we probably aren't, but would be good if they did. Real Might throw some confusion in those learning objectives. Um, so ultimately, what we decided was, thank goodness for the helper, time skips were okay. See, all that hemming and hawing, and we just went back to time skips anyway. Because when you're using that dead time or taking an action with the player, you're able to rely on the helper to go work on the other patient. And we're looking at the flow, we just found it still managed to work. It definitely did require significant changes into where the time skips took place, because what we had as a time skip in one curriculum or the other definitely didn't fit right in that same spot when trying to combine them. Hopefully that all made sense. All right, so what do you do when the mother and the baby are both sick? What do we do if there are twins? The procedure says to check for twins. Well, what if we have a scenario where there's a twin? How does this, what do you do first? How does this impact the flow and our prescribed actions of what is the correct next step? Well, we decided to just simplify this by saying we're never going to have twins. We'll check for it as part of our procedure, but it's never going to happen. And our mother and baby are just not going to be sick at the same time. Um, so our helpers manage one patient, and the provider will do the other. And realistically, they'd never do both anyway, so that still works. And we decided just the learning objectives just didn't warrant that increased complexity. So we just kept it simple.
Thank you,
All right.
Matt. You know, we're going to have to wrap shortly, but I want to thank
Okay.
you for pointing those important. Go right ahead and wrap, please.
All right, talking faster. Variable tracking. So in one scenario or the other, there's basically prescribed, what's next. But when you combine, they go then the looping nature of the flow requires a lot more tracking of, okay, has this happened already? So we have to track a lot more variables based on what's already happened in order to make the flow work. So that just is technically trickier, and the order in which the merging happens. So at this point, do you take care of the mother first or the baby first, or what? Different things happen at supposedly the same time. So it's really important that you work with subject matter experts to make those final calls over how things should fit in. So as a technical person without that expertise, you would never be able to make those decisions. So to sum up, this virtual training is a really good add-on to in-person training and online training. Um, and the addition of these maternal scenarios is complex, and there's just a lot of design decisions we had to make in order to make it work. So I want to thank all our partners at the University of Lagos and eHealth for Everyone for helping with our research and our development. Couldn't have done it without them. And thank you for everyone at the University of Washington that helped with the development in this project. And thank you to all of you for being here.
Oh, we are so thankful for both of you. And those design decisions you made, they make perfect sense. While the mother and baby in life would get sick at the same time, you have to make those decisions so they're focused on task. We want to thank you and Rachel for a fascinating session. And I'm so sorry to cut in on your wonderful talk. Let's see. And of course, let's see, here we go.
No worries, I ramble.
No, but that was exciting, and I love that. The failure-based learning, that's wonderful. So as a reminder to our audience, you will want to check out the conference.opensimulator.org to see what is coming up next on the schedule. You won't want to miss our next session, which will begin at 5 o'clock p.m. in this keynote region, and it's entitled Enhancing Secondary Students' Self-Efficacy through virtual world-based learning. Also, we encourage you to visit the OSCC 25 Poster Expo in the OSCC Expo 3 region to find accompanying information on presentations and to explore the Hypergrid tour resources in OSCC Expo 2 region, along with our sponsor and crowdfunder booths located throughout all of the OSCC Expo regions. Thank you again to our speakers and the audience.